Good afternoon, ladies and gentlemen. Welcome to APSC JCS 2020 webinar, the session, webinar 1, Cardiometabolic Disease in Asia. So I'm Sata from Tokushima, Japan. I'll chair this session with Professor Nicholls from Australia and Professor Yeo from Singapore. So first of all, let me introduce co-chair Professor Yeo. So Professor Yeo, please.
Thank you, Professor Sata. It's a pleasure to be here. This is the first of the APSC JCS sessions, and it's very nice to lead on this with the first session on cardiometabolic diseases in Asia. I think this is an important topic, and this afternoon's session will have talks on dyslipidemia, statin treatment, diabetes, as well as fatty liver. We have a session being endorsed by the Asia Pacific Cardiometabolic Consortium as well. And with us today for our speakers, as you have heard, following this talk, I'll be introducing Professor Steve Nicholls from Australia. And then we have also our friends from Professor Junya Ako from Japan, Professor Lee from China, and Professor Reyes from the Philippines. So with that introduction, I'd like to hand over to Professor Stephen Nicholls. Steve is a friend and from Monash, a heart institute in Melbourne, Australia. And he's going to be talking to us on the SGLT2 inhibitors and heart failure, an overview of the evidence. Steve, over to you, please.
Thank you, KK. Thank you, Dr. Sata and Dr. Yeo, and thank you so much for the invitation to speak this afternoon. What I'd like to do quickly is to just overview what has been a rapidly progressing area in the last few years and how we've been able to translate early findings of beneficial impacts on SGLT2 inhibitors on heart failure outcomes in studies that were primarily designed to evaluate the impact of these agents on atherosclerotic cardiovascular events, and how we're now translating that to clinical trials in the pure heart failure space and what that might mean for clinical practice moving forward. This slide summarizes my disclosures. So we continue to have a considerable unmet clinical need in heart failure. First of all, from the heart failure with reduced ejection fraction perspective, while we have many evidence-based therapies, few patients receive all of them. And even when our patients do take a number of these evidence-based agents, cardiovascular outcomes remain poor, with 5-year mortality rates in HFrEF remaining as high as 75% in many countries. From a heart failure with preserved ejection perspective, while we have increasingly recognized the importance of that kind of syndrome in the clinic, we fail to have any specific treatment options for these patients. And then finally, in the setting of cardiorenal syndrome, we have no specific treatments that consistently provide sufficient cardiovascular and renal protection in all clinical settings for our patients with heart failure. Now, when we look at the seminal cardiovascular outcome trials of SGLT2 inhibitors, which were conducted exclusively in patients with type 2 diabetes, while we have seen heart failure signals in terms of clinical benefit, it's important to note that the percentage of patients in each of those trials with clinically manifest heart failure prior to study entry was relatively low, in the order of 10 to 14%. But as we saw in 3 large clinical development programs, hospitalization for heart failure, or its composite was cardiovascular death, was consistently and robustly reduced, whether it was with empagliflozin, canagliflozin, or dapagliflozin, again, in studies that were primarily designed to evaluate the cardiovascular safety and potential atherosclerotic efficacy of these agents in patients with type 2 diabetes. When we looked further at those studies, you see a fundamental and potential important difference between atherosclerotic cardiovascular events and heart failure type events in the patients in these studies with either established cardiovascular disease or the more primary prevention setting on study entry. When we looked at the conventional major adverse cardiovascular events, and that included myocardial infarction, non-fatal stroke, the benefit of the SGLT2 inhibitors in those studies appeared predominantly seen in the patients who had an established prior history of cardiovascular disease, and we saw no benefit whatsoever when we looked at the more primary prevention patients that were enrolled in either DECLARE or CANVAS. In contrast, when we looked at hospitalization for heart failure as a potential clinical benefit in those studies, not only did we see a benefit of SGLT2 inhibitors in the patients with clinically manifest cardiovascular disease at study entry, but in fact, the asymptomatic primary prevention patients also appeared to derive some sort of benefit. And it does raise the question, and when combined with the studies that have been performed to date looking at renal outcomes, that while we see atherosclerotic events reduced in the more secondary prevention patients in the SGLT2 inhibitor trials, we actually see a much broader clinical benefit with these agents, not only importantly reducing both renal and heart failure events when we look at that much broader kind of primary prevention kind of cohort. Now, when we kind of take a step back and start to think, okay, well, why might SGLT2 inhibitors be favorable for heart failure outcomes? And is there a potential rationale for using these agents in a non-diabetes setting? We've now understood with a lot of work that's been done back in the lab that these agents possess a number of functional properties which may, in theory, have a favorable effect on heart failure. We know that diabetes and heart failure have similar pathophysiological features. We've seen mechanistic effects of SGLT2 inhibitors that are seen in patients with and without type 2 diabetes. And we know that the cardiovascular benefits of SGLT2 inhibitors in the large cardiovascular outcome trials are largely independent of glucose levels. And so it's really those observations that have led to the conduct of new large clinical trials that have focused on the potential clinical efficacy of these agents in a more dedicated heart failure setting. The first of these large trials reported was the DAPA heart failure study. This was a study of a little over 4,700 patients who had symptomatic heart failure with reduced ejection fraction of at least class 2 for at least 2 months. They had to have a documented ejection fraction less than or equal to 40% within the last year, an elevated pro-BNP level, and they had to be treated with appropriate standard of care evidence-based therapy for HFrEF. Patients were randomized to treatment with dapagliflozin or placebo, and the primary endpoint of the study was time to first occurrence of any component of the composite of cardiovascular death, hospitalization for heart failure, or urgent heart failure visits. Here are the key baseline characteristics of the study. Patients with a mean age in the mid-60s, predominantly male. 2/3 of these patients had class 2 symptoms, mean ejection fraction 31%, a little over 50% the etiology of heart failure was ischemic, and a little under 50% of patients had type 2 diabetes on study entry. In terms of concomitant medication use, these were extraordinarily well-treated patients. More than 90% of patients receiving diuretic therapy, a RAS blocker or a beta blocker, high rate of use of a mineralocorticoid receptor antagonist, and a small rate of use of kind of electrical therapy for patients with symptomatic heart failure. When we looked at the primary outcome in that study, the time to first event of cardiovascular death, hospitalization for heart failure, or urgent heart failure visit, you see that there is a highly significant, robust benefit in favor of dapagliflozin, with the event curve separating fairly early in the context of that trial. When we look at the major individual components of the primary endpoint, whether we look at worsening heart failure event or cardiovascular death, again, we see very comparable benefits, both clearly in favor of the SGLT2 inhibitor. And when we looked at the subgroup analyses for the primary endpoint, we observed really no major subgroup where we didn't see benefit. Importantly, the less symptomatic patients with heart failure, those class 2 patients, appeared to derive a greater benefit than the patients who were on a class 3 or 4. Importantly, from the context of this study and the objectives that it was trying to meet, when we looked at patients with or without type 2 diabetes at baseline, we saw clinical benefit in favor of dapagliflozin in both of these groups. In fact, a very comparable degree of benefit, suggesting that the heart failure benefit could be observed in patients that regardless of their degree of glycemic control at study entry. Now, with these patients, it's not only a first clinical event that is important for many of these patients. We know that heart failure is often characterized by recurrent presentations to hospital, resulting in an increasing burden on the healthcare system. And so when the investigators in study looked at total heart failure hospitalizations and cardiovascular death, they observe again a similar benefit in favor of dapagliflozin, which has potential major health economic kind of considerations for healthcare systems. Beyond the hard endpoints, when we looked at measurements of symptom scores, the Kansas City Cardiomyopathy Questionnaire, we see a greater improvement in that score in the dapagliflozin group compared to placebo. And if we look at that a different way and look at patients who either have a significant increase in that score or a significant deterioration in that score, we see a greater percentage of dapagliflozin patients have a significant increase in this cardiomyopathy questionnaire score. And importantly, less patients in the SGLT2 inhibitor treated group having a significant deterioration, suggesting a potential impact on quality of life above and beyond the conventional hard measures that we typically focus on in large clinical trials. The authors similarly reported a nominal reduction in all-cause mortality in favor of dapagliflozin. Again, this was down the statistical hierarchy. It is a nominal observation, but it is important the way that it goes hand in hand with the other observations from this study. And then finally, and critically, this agent was safe and well tolerated. And that is important given that many of these patients with heart failure have other comorbidities, a number of other concomitant therapies. And so adverse events are critical, particularly if we're looking at introducing new pharmacotherapies for use in these patients. If anything, we saw nominally less serious adverse events in the active treatment group compared to placebo. So efficacy across the board accompanied by safety and good tolerability. Now, this is the first installment in looking at SGLT2 inhibitors in the heart failure space specifically. There are ongoing studies and a number of other programs beyond the 4 studies that are demonstrated on this slide, showing that there's activity both with multiple SGLT2 inhibitors, but also looking at different clinical settings, looking at their impact in HFrEF, HFpEF, and in milder and more severe forms of disease. So they will help to continue to inform how to best use these agents in clinical practice. So in summary, Mr. Chairman, a reduction in heart failure-related events has contributed to the benefit of SGLT2 inhibitors in the seminal early type 2 diabetes cardiovascular outcome trials. This benefit can now be extended to patients with heart failure in the presence or absence of type 2 diabetes. Ongoing trials will attempt to define their role in various heart failure patterns and in severity of heart failure symptoms so that we can more optimally determine how to use these effective agents effectively in the clinic. I'll thank you for your attention.
Thanks, Steve. That's a very nice talk. So we have now some time for Q&As, and maybe just to remind the audience, you can type in your questions in the Q&A tab in Zoom, and you can type it in Japanese as well. And Professors Sata and Ako would be happy to
translate. Yeah, okay.
Yeah, but maybe let me get the ball going and then fire some questions. Steve, in terms of the role of the SGLT2 inhibitors in heart failure and in a diabetic patient to boot, if you had a choice, which one would you use first, dapagliflozin or Entresto?
Well, I think the evidence is probably going to ultimately come out in favor of the SGLT2 inhibitors. And I suspect that will be a combination of the fact that I think clinicians will fairly broadly feel a greater degree of comfort in the use of these agents in clinical practice. I think that where agents have demonstrated benefit across a range of different clinical syndromes, I think that it just kind of contributes to a greater ease of use. That will clearly be supported when we have more lines of evidence to support their use from clinical trials. And that's why the ongoing trials are really critical in terms of how they will inform. Now, if the subsequent trials were to reveal discordant results, well, then that may be the game changer that may flip things back in favor of Entresto.
Any comments from the the other chairs and panelists and speakers?
Yes. Hi, Stephen. This is Junya. So my question is, there appears to be a difference between HFpEF versus HFrEF in terms of its efficacy. And do you have any comment or any mechanistic insights or possible?
Well, I think that this is one of the major questions in the heart failure space, that I think we need to remember that heart failure is a clinical syndrome, and it is all not just one disease. And we have been trapped before with other classes of heart failure therapies where there've been a clear benefit for HFrEF, but we've been unable to demonstrate the same for the preserved ejection fraction setting. And Entresto is a good example of that. It was interesting in the paradigm study where in fact the patients with HFpEF, but perhaps at the slightly lower kind of end of the ejection fraction spectrum, may have still actually derived some sort of benefit. So I think that's why there's considerable ongoing attention to try and understand the mechanism underlying heart failure with that preserved ejection fraction setting. Does that have implications for why we might be more likely to see a benefit with an SGLT2 inhibitor? Who knows? It has enormous implications for the development of novel therapies for HFpEF. And it's important because we see so many patients who present to the emergency department of the coronary care unit with this clinical setting. And with an aging population, it's only going to become much more important.
Thank you.
So I have a question. So you show that the SGLT inhibitor might be effective heart failure patient with or without diabetes patient. So is it common for you Australian to use SGLT to non-diabetic heart failure patient?
Not today. Not today. So today our use of these agents are largely restricted in the diabetes setting, but we will quickly see an expansion of that, I suspect. That'll be driven clearly with more data that comes into the system, and I think that's many of us have thought for a while now that these agents will become increasingly a cardiac kind of therapy as opposed to a diabetes therapy. And I think that, from a cardiologist perspective, where we've seen a need for more and more cardiologists to use these agents for high-risk patients with type 2 diabetes, perhaps increasing comfort in their use in the heart failure setting may actually kind of contribute to more use in diabetes as well.
Okay, thank you.
I'm curious, across the countries, in Japan, is it an approved indication for use such that you will get reimbursed if you use the SGLT2 inhibitor in a non-diabetic heart failure patient? Are you allowed to use it?
Not yet, but it will be allowed this fall, I think. So it's in the Shonin process right now. So
what about Eugene, for you in the Philippines?
Recently, the FDA announced approval for heart failure. Even after the clinical trial was presented, many started using it even in non-diabetic heart failure patients. So I think it's the direction right now. It's becoming famous. And me personally, I see a lot of benefit with the use of SGLT2, even in non-diabetic heart failure patients.
Right. And
So
Dr. Lee, what about in China? I think you're muted, Dr. Lee. Okay, well, I guess while we're waiting for Dr. Lee, I guess in Singapore we can use it in non-diabetic heart failure patients, and as my heart failure colleague reminded all of us, he had to remind the residents and other house staff that, hey, look, don't label a patient as diabetic just because they're on, an SGLT2 inhibitor, which was kind of an interesting thought for all of us to share. So I think that's a reason why we thought that this topic had fit in nicely with the whole cardiometabolic arena, because of a lot of the overlaps, and treatments that were previously purely for diabetes has now clearly entered another domain of use. So that is, I think, worth talking about. There is a question, actually there are two questions and maybe we can address them. The first question, which I'll read out, are there any biomarkers which encourage you to use SGLT2 inhibitors rather than ACE ARB for chronic heart failure patients? Steve, do you know, or Junya, or Dr. Sata, Eugene, Prof. Lee?
I think it's about treating the patient. I think that's always been such an important thing with heart failure. So it's really about the symptomatic patient on therapy who will derive benefit.
Yeah, I don't think that's really been answered. So I think there's no good biomarker yet. And then maybe the last question before we move on to the next speaker. Would you routinely adjust diuretic dosing prior to SGLT2 inhibitor administration? Is there a rule of thumb for SGLT2 inhibitors and furosemide dosing? That's a good question. I don't know. I don't think so.
But I usually adjust diuretic dose. I usually, maybe for those patients who's taking furosemide 20 milligram, then I will cut 10 milligram. 40 milligram, then I'll cut that to 20 milligram, for instance.
Okay, I think for now it's largely, I don't think there's any golden rule, but it's probably good to use your own experience and to, example from what Professor Ako said, that's a good suggestion. Professor Sata, yourself, any questions for Professor Reyes?
Yeah, so I have a question to Professor Eugene Reyes. So regarding treatment, so recently SGLT2 inhibitor has a focus about the fatty liver treatment. How do you think about SGLT2 inhibitors?
Well, by pathophysiology or physiologically speaking, SGLT2 is associated with weight loss. And this weight loss is, of course, part of the possible benefits that you can get in people with fatty liver disease. But of course, there are no studies. I don't know with the Professor Yo, if you have any data on fatty liver disease and SGLT2. I don't think they have studied it yet, but there are maybe some small publication.
Yeah, I think a small number of patient publication SGLT2 are reported to be effective in reducing fatty liver. Yeah.
So, but they haven't put it in the guidelines yet.
Not yet. So we need a clinical study to put them into guidelines.
Yes, agree.
I think one of the challenges with this whole arena is that the measurement of fatty liver and steatohepatitis is not straightforward. You need a combination of blood biomarkers and some form of imaging. And if you use ultrasound is one thing, if you use CT scan or MRI is another thing, and specific sequences are required for the MRI. And some do, use the fibroscan. So those studies that were quoted in the meta-analysis, I saw nicely in the summary that Eugene showed that some use a CT and some use ultrasound and some use just the AST and ALT. So that does make life a bit complicated in terms of having a uniform measurement to define what constitutes fatty liver. So that would be a challenge for all of us.
Yeah, I agree. That is, we need to standardize the definition of fatty liver disease based on imaging. And I think based on the publications that I have reviewed, they have different types imaging that use. But the standard right now is, of course, histopath, but by biopsy. But, who would like to get biopsied, right?
Yeah, that's nasty. Okay, I think maybe we can go to Dr. Lee again. Dr. Lee, do you want to try your sharing your slides? As I think we won't have video, maybe just your slides. Give it a try? Okay, you can see your slides. Go ahead, please, Dr. Lee. So maybe I'll just ask for a quick, statement from all the panelists. How many percent of your patients complain of one form of the or another of side effects that would stop them from using their statins? Maybe just starting with Professor Sata.
Yeah, so it's not so common, very rare in country. I'm not sure, but I think it's below 1%, almost 0.1% or something. Yeah. I don't know the accurate number. How about Professor Ako in Japan?
I think in Japan, it's less than, definitely less than 5%, but we sometimes encounter patients that complains muscle weakness or muscle pain that leads to the discontinuation of statins. But those patients don't show any elevation in CK or whatsoever. So basically, many patients complain that muscle weakness, pain, but that's kind of without objective findings, only a subjective complaints.
Steve?
Unfortunately, it's probably more common in Australia. I probably end up having a conversation with somewhere between 10 and 20% of my patients at some point in time about side effects. That doesn't mean that they all come off the medication, but it's not uncommon that I will need to have a conversation, particularly using higher intensity statin therapy. Some patients won't continue therapy. Some patients will take lower doses. Some patients will actually kind of tolerate symptoms if they understand the benefits that the medication is affording. And so, unfortunately, it is a far more common conversation here than I suspect it is in Japan.
Yeah, maybe that one reason that we are seeing less side effects is that we are only allowed to use a lower dose of statins. And that may be the reason, that one possible reason.
Yeah, I agree. We use 5 milligram atorvastatin, 2.5 milligram rosuvastatin. That is common in Japan. Small, very small dose.
But my practice is a 20 milligram atorvastatin always, and 10 milligram rosuvastatin always. That's the maximum dose allowed to use in for Japanese patients.
What do you mean by you are allowed to use? The government actually prohibits a higher dose?
Yes.
Wow. That is.
Or actually, those are the maximum doses allowed to be reimbursed. To be correct.
Insurance.
I see. Okay. What about the statin intolerance for you, Eugene? I mean, in the Philippines, is it common?
It depends on the age group that you're treating. It's kind of common in the elderly. In the young, not so much. When I say young, they're less than 60 years of age. But when you look at people in the range of 60 plus age and up to 80, they always complain of muscle pain. And sometimes I do not know if it's really due to the statin, but there is a definition of myalgia associated with statin based on the guidelines. You have to test this, you have to do this, and etc., etc. But what I do is I withdraw the statin temporarily and put it into a low dose. But many of these patients, the elderly, are already on low dose statins because they are frail, and they usually complain of not the usual big muscle pain that that we usually see in young people, but the pains that you cannot explain. So it's kind of common based on age group, but in general, if you look at the data, it's not common overall. So
It's it's a very peculiar problem. I don't know whether Dr. Lee, if you are able to speak, can you comment on what the experience in China is like? Dr. Lee has been in communication with me on the phone. I think he's having some problems with the internet, so we'll let him join when he can. But one of the challenges we have had is that the data from the randomized controlled trials and the placebo arms, and when you look at those numbers, it appears that the true incidence of true statin intolerance is not high, but yet in the real world experience the numbers are higher. The question is, are those nocebo kind of effects, or are those real symptoms? So it's been tricky for us to tease out. But for sure, if patients feel that they are having a side effect, then they won't take it. They won't take their statin. In that regard, I'm going to ask all of you whether you all believe, I guess is a good word to use, believe that coenzyme Q10 helps in helping with some of the statin intolerance or myalgia side effects. Eugene or Steve or Junya or Professor Sata, any experience with coenzyme Q10?
Yeah,
Maybe
so we can prescribe coenzyme Q10, but it's not common. So we need a clinical study to prove that coenzyme Q10 is effective in prevention of statin intolerance. Yeah.
Steve, what is your experience with coenzyme Q10? Does it work?
I don't proactively prescribe it. I have patients ask me about coenzyme Q, and I will tell them that there are some theoretical advantages, that there really isn't good evidence from clinical trials, and it costs money. It will be out-of-pocket expense to the patient. Some patients are prepared to do that. In the end of the day, I think the bigger challenge is to really try and see if you can get your patients onto any effective dose of a statin. And that may mean starting with very low dose therapy 1 or 2 days a week, and trying to increase the dose of that slowly. I focus a lot more on that. And the patients understand that. They understand, because then you've really conveyed to them, look, these agents are important. It's critical we get you onto some effective dose of the drug. And we're going to just start low and go slow. That can often be that can often produce some sort of effective lipid lowering, which, and then given in combination with, say, ezetimibe, can actually be quite good for many patients.
I've only used it in limited situations, but some patients do claim to feel less myalgias. But I wonder how much of it is placebo and how much of it is not. But sometimes I use the placebo effect to my own benefit, because if I know that the true incidence of statin intolerance is low, and this is a nocebo effect I'm dealing with, then the placebo effect might help my patients after all. So we'll use that as a tool. On the rest of the cardiometabolic arena, any questions from the co-chairs or the speakers that you'd like to bring up for discussion? There is a question in Japanese, which I can't read. I might have to trouble Professor Sata or Professor Ako to translate for us.
Oh, so in Japanese Q&A question says some trouble in the internet system. So not the medical question.
Oh, okay. Right. Any other questions from from anyone on the relationship between cardiometabolic disease and heart disease?
So let me ask one question. So about SGLT2 inhibitors, I think Asian diabetic patients less obese as compared with Caucasian patients. But does SGLT2 inhibitor work as good as in Caucasian patients? Or I think it works very much the same way as Caucasian patients, but so for those SGLT2 works as good as Caucasian patients.
Yeah, I agree. I think the challenge and was pointed out, I think by a number of the talks is the typical lack of representation of Asian patients in many of the studies that we do. But there's no sense that the efficacy of SGLT2 inhibitors is less in Asian patients, which I think is very reassuring.
Yeah, the patients I've had who have been on SGLT2 inhibitors have lost weight as well, despite their slim figures. They've become a bit more slim. So, I mean, I think it does work in that regard. There is one more question that just appeared on the Q&A, and maybe I'll just read it out. So this is an interesting question. How does the statin tolerance in renal failure, is there issues of safety in or even efficacy in renal failure patients in preventing cardiovascular disease in renal failure patients with the use of statins? Steve, you want to?
I think the last part might be easier than the first part. I think the early studies in renal failure were disappointing and confusing. I think we then saw the benefits of the combination of simvastatin and ezetimibe in the SHARP study show benefit, and that was important because I think it did show that lipid lowering could modify risk in patients with significant kind of renal disease. I think the subsequent kind of analyses of those studies have demonstrated that the benefit is predominantly in patients who are not on dialysis. And that was important because the early statin trials in CKD were largely in dialysis patients. So I think it is probably about picking where we think modifiable risk is. We have many patients with significant renal dysfunction short of dialysis that we would all consider to be high risk, and that the benefits of lipid lowering, I think, are fairly clear there. As for tolerance of statin therapy in patients with significant kind of renal dysfunction, I think that this is a group of patients where tolerability can be more of a challenge. I don't think there's any magic bullet in how one improves statin tolerability in those patients compared to non-renal patients.
Junya or Professor Sata or Eugene, any additional comments? There is certainly a lot of, at least another question on statin safety. For an elderly patient with poor renal function or who are frail, do we consider starting high intensity statins or a lower dose? Does it make a difference to you if you see a frail elderly patient? Maybe Junya?
Maybe so those who are elderly patients, that means I think for those frail patients, I would like to prescribe lower dose of statins rather than higher dose of statins. So that's my practice, but that's what I do, but not based on the solid evidence.
Right.
How about you, KK?
I generally would still start at the standard dose. I generally think that some of these patients have complex. They don't usually have just one problem, and if they come to see me for an acute coronary syndrome or have cardiovascular disease, I tend to treat them aggressively. I think the concerns about statin treatment and side effects tend to be um, a bit of strongly felt in our community, and I usually try to allay those concerns. I usually say that, look, if you have problems, we can always reduce the dose, but right now I want to start at what is guideline recommended so that we can reduce their risk of a subsequent event. And as long as they understand that that we have the option of going back should they have a problem, I think they seem to be comfortable with that notion. So I generally will still start with high intensity statins in patients who present with acute coronary syndromes.
Yeah,
But I don't think there's necessarily a one size fits all answer. If sometimes I give a high dose statin and then the patient comes back a few months later and say, yeah, doc, I've been taking half the dose because I read on whatever, and then so if they don't buy into it, then there's no point me prescribing. So I think it's on, oftentimes you have to adjust it to your patient, your individual patients and your community.
Yeah.
Is that the way it is for you, Eugene, as well in the Philippines?
Yeah, somewhat the same. Um, Although the evidence in patients with, elderly, uh, they were the ones who were excluded in most of the clinical trials, and that's the reason why we have limited evidences on them. But in my practice, I give them low dose statins because they are the ones who really have side effects, and most especially polypharmacy. They receive a lot of drugs, and that's where I look for drug interactions one by one. And sometimes I prefer one statin over the other because of certain drugs that they're using.
Okay, thank you. Professor Sata?
Yes.
I think it's maybe a good time to close the session.
Yeah, I think so. So can you close this session, or I'll close? Okay, so I would like to close this session. So we had a wonderful talk from Asia and Australia, Asian Pacific Society of Cardiology members. So I hope this fruitful discussion will lead to the prevention of cardiovascular disease in this area. So thank you, Chairman, thank you, audience, and thank you, the speakers. Thank you very much. I will close this session.
Thank
you very
you.
much.
Bye-bye.
Bye.
Bye-bye.